Hi guys, I'm Dr. Ashutosh, third year PG in medicine, and today I'm going to discuss some of the important topics for PG entrance exam. Now, our topic for today is channelopathies. Channelopathies. Now, what is channelopathy? Muscle membrane excitability is affected in a group of disorders, and this is called as channelopathies. Now, these channelopathies can causes episodic muscle weakness. It's also called as periodic paralysis. Means paralysis in periods, and it also causes myotonia or paramyotonia. We'll discuss this later. First of all, we'll concentrate on calcium channel disorder of muscle. Now, calcium channel disorder of muscle causes hypokalemic periodic paralysis. This is acronymed as hypo-K periodic paralysis. And another channelopathy is sodium channel disorder of muscle. This causes hyperkalemic periodic paralysis. Hyper KPP. Now, in both channelopathy, there is a defect in calcium channel or sodium channel, which causes hypo or hyperkalemia. So, it is not related to potassium channel. So, we should not get confused that it is due to potassium channel defect. It is due to calcium or sodium channel defect. Now, first we will discuss the hypokalemic periodic paralysis, which is caused due to calcium channel defect. It is of two types, type 1 and type 2. Type 1 is most common, and it is caused due to mutation in calcium channel gene, which is located in skeletal muscle. It is a voltage sensitive calcium channel gene which is located in skeletal muscle, and mutation it causes type 1 hypokalemic periodic paralysis. Now, type 2. Type 2 is due to voltage sensitive sodium channel gene, that is SCN4A gene, and it's 10%. So, question may arises that hypokalemic periodic paralysis is due to calcium channel or mutation calcium channel gene, or mutation voltage channel gene, or both or not. So, answer should be both, because 10% in 10% cases there is a voltage sensitive sodium channel gene defect. Now, hypokalemic periodic paralysis is an autosomal dominant disorder, and it mainly occur, or onset is mainly in second decade to third decade of life, that is 25 years and above. Mainly affect adolescents. Males are more affected than the females. decrease penetrance of gene in females. Now we will discuss on the precipitating factors for hypokalemic periodic paralysis. What are the precipitating factors for hypokalemic periodic paralysis? The precipitating factors is meals which are rich in carbohydrate and sodium. Meals which are rich in carbohydrate and sodium precipitate the hypokalemic periodic paralysis. And another precipitating factor is rest after prolonged exercise. So rest after prolonged exercise also precipitate it. Now proximal limb muscles are more affected than distal limb muscles. So proximal limbs muscle, whether it is of upper limb or it is of lower limb, they are more affected than the distal limb muscles. Now ocular or bulbar muscles are less affected or generally spared. Respiratory muscles are generally spared. Respiratory muscles are spared, but if they are involved, they may cause severe precipitation of disease or maybe life-threatening. Generally, it is resolved in 24 hours, but sometime may take longer than 24 hours. But generally, 24 hours it is resolved. Now, our main concern is decrease in potassium ion in body in serum. So decrease in potassium ion can causes life threatening cardiac arrhythmias. So it is our main concern that life threatening cardiac arrhythmia should not occur. Some late complications occurs. What are the late complications? Late complication causes severe disabling proximal lower extremity weakness. In lower extremity, the proximal muscle are severely disabled, so it is a late complication of hypokalemic periodic paralysis. Now, what is a DD? Differential diagnosis of hypokalemic periodic paralysis is thyrotoxic periodic paralysis. It's a DD for hypokalemic periodic paralysis. How we diagnose hypokalemic periodic paralysis? Diagnosis is made by EMG studies and NCS studies. EMG is electromyograph and NCS is nerve conduction studies. So EMG shows electrical silence and NCS so decrease in amplitude. but most important test is serum potassium ion test. Serum potassium ion is decrease in attack. So if serum potassium is decreased in attack, we will diagnose that it is a case of hypokalemic periodic paralysis. Okay. Now, how we treat hypokalemic periodic paralysis? So in mild cases, it is of not much concern. It is spontaneously recovered. So usually we give no treatment in mild cases. In mild cases, no treatment required. Spontaneously recovered. But in moderate to severe cases, oral potassium chloride, oral KCl we give, and 0.2 to 0.4 millimole per kg given every half hourly. IV KCl generally not needed, but when we need IV KCl in when patient have swallowing problem or vomiting, recurrent vomiting, or he or she has swallowing problem. Other treatment models: decrease in carbohydrate, decrease in sodium in diet, and ask patient not to do intense exercise. Okay, so this was hypokalemic periodic paralysis. Some other treatment which are given in hypokalemic periodic paralysis is acetazolamide. These are drugs which are used in hypokalemic periodic paralysis: acetazolamide or dichlorphenamide. These are not used in acute attack, these are given for prophylaxis. But we should not use, these are contraindicated in type 2 hypokalemic periodic paralysis. These are contraindicated in type 2 hypokalemic periodic paralysis because it precipitates the attack. Now we will discuss about hyperkalemic periodic paralysis. Hyperkalemic periodic paralysis, it is due to mutation in SCN4A gene, the same gene in which was mutated in type 2 hypokalemic periodic paralysis, but there was hypokalemia, and in this mutation there is hyperkalemia, is voltage gated. The term is misleading. Hyperkalemia, the term is misleading because potassium ion level is often normal, but the term is justified because this disease is precipitated by potassium supplements. If if we give potassium supplements to the patient, this is precipitated. So the term is justified hyperkalemic potassium paralysis. Now the disease of onset is first decade of the life. Males and females are equally affected. Attack lasts for 30 minutes to few hours. Weakness is same like hypokalemic periodic paralysis, that is in proximal muscle. Bulbar muscle spared. Precipitating factor of the attack is rest following exercise and fasting. Now diagnosis same, EMG and NCS. EMG shows silent and NCS shows decreased amplitude of motor activity. Amplitude is decreased in NCS studies, and there is silence of myotonic discharges in EMG. Now, what is the treatment? Treatment is acetazolamide or dichlorphenamide. Maxilatine can be used in severe cases. Another disease, another channelopathy is paramyotonia cognitia. Paramyotonia cognitia. Now, it is also an autosomal dominant condition, and the defect is in sodium channel gene. Weakness is generally mild. There is a cold intolerance, or we cannot call it cold intolerance, we can call it cold induction of weakness. Due to cold weather or cooling effect on the muscle, there is weakness. Now, clinical feature is myotonia. What is myotonia? Muscle weakness. But myotonia increases with muscle activity. That's why it is called as paradoxical myotonia. Why it is called paradoxical myotonia? Because in classical myotonia, the muscle activity, the myotonia myotonia elevates, but in paramyotonia cognition with muscle activity, it get worsened. So it is differentiating point from classical myotonia. Serum CK level, creatinine kinase level is mildly elevated in it. When we do routine NCS, it is normal. But short exercise NCS test with cooling of muscle may show decreased in amplitude of compound muscle action potential. EMG may show diffuse myotonic potentials. But when we cool the muscle, the myotonic discharges disappear. So it is cold induced myotonia. Myotonia cognition is cold induced. It's a very important point for paramyotonia cognition, that is cold induced, and exercise with exercise the myotonia increases, which is differentiated from paradoxical myotonia. Is differentiated from classical myotonia. Sorry. Now, what is the treatment? Treatment is maxilatine. Now we'll move forward to another channelopathy, which is potassium channel disorder. Potassium channel disorder. It is a name disorder. Name is Anderson Tawil syndrome. It is a syndrome. So in this there is episodic weakness with cardiac arrhythmia plus dysmorphic body features. Now cardiac arrhythmia is life threatening. What are the cardiac arrhythmias? It's long QT, ventricular ectopics, and bidirectional ventricular arrhythmias. There's a mutation in KIR 2.1 gene. KIR, the full form is potassium inwardly rectifying gene. Which causes increase in muscle excitability. Now, what is dysmorphic feature? Dysmorphic features are short stature, low set ears, scoliosis, clinodactyly, hypertelorism, micrognathia, small mouth, and broad forehead. Now treatment is acetazolamide because there is high potassium concentration in serum. There is another channelopathy, chloride channel disorder. Could be autosomal dominant, could be autosomal recessive. Autosomal dominant is Thompson disease. Autosomal recessive is Baker's disease. Thompson's disease is mild form and Baker is moderate to severe form. Both is caused due to mutation in chloride channel 1 gene, CLCN1 gene. Onset infancy or early childhood. Severity decreases with age increases. There is also myotonia, which is increased due to cold induced myotonia, just like in paramyotonia cognitia is also induced by cold, but differentiating feature is it decreases with walking. Gait slow or labored initially, which improves on walking. Muscle hypertrophy present. Now, what is the treatment for this disorder? Treatment is maxillative. So this concluded the calcium channel disorder, sodium channel disorder, potassium channel disorder, and chloride channel disorder and paramyotonia, and this concluded our channelopathies. Hope you like it.